Hello, everyone. Good morning, good afternoon, or good evening from different parts of the world for being a part of this webinar on retinopathy of prematurity. I'm Dr. Eli Pradhan from Kathmandu, Nepal. So I'm going to talk on retinopathy of prematurity. As you all know, today is the World Prematurity Day. It's November 17th is marked as World Prematurity Day. So I'm glad that I'll be talking on one of the complications the premature baby will have. I work as a consultant medical retina in my institute, looking after diabetic eye, macular degeneration eye, and more into retinopathy of prematurity these days. So this is the place where I work with no financial disclosure and conflict of interest. So with this, I'll be, going through definition of, because this is kind of a basic level for, regarding retinopathy of prematurity. So I'll be going in quite a basic level, definition, risk factors, screening guidelines, diagnosis, treatment in regards to lasers, anti-VEGF, and of course, I'll be touching a little bit about the role of tele-ophthalmology for screening of retinopathy of prematurity. So retinopathy of prematurity is the vasoproliferative disorder of the retina or abnormal retinal vasculature in premature babies, which is one of the leading causes of childhood blindness, and it is in fact preventable cause of blindness if it is, seen if it is diagnosed early and treated. Now, this is, I haven't kept like a proper slide for the number of blind because of, ROP, but there's a pooled prevalence by meta-analysis. What has found that, 31.9% of ROP worldwide, that is done in as the meta-analysis published in BMJ Pediatrics, and also about out of 31.9% of prevalence of ROP, 7.1% has a severe ROP needing treatment. So the preterm, let's define preterm. It is the preterm is defined as babies born alive before 37 weeks of pregnancy. It can be categorized as very extremely preterm, that is less than 28 weeks, very preterm 28 to 32 weeks, moderate to late preterm 32 to 37 weeks, and nowadays it is seen even more in late preterm babies having the similar symptoms of ROP. And with this, in the modern technology, more babies are being alive. And the earliest baby alive is 21 weeks. And the smallest birth weight is 240 grams. That was in 2023, the baby was born in Iowa. And the baby she is still alive with all those support, I know. So we can imagine that with the new intervention and new technology, more and more babies are alive. But the effect of going side by side on the eye when there is no proper screening technology and there's no awareness among us, they're getting more blind, and that is causing the burden to the ROP blindness. Now, as you can see, this ROP, it is coined by Terry in 1942. And afterwards, that was the first time he has mentioned about retinopathy of prematurity, which was mentioned as retrolental fibroplasia, because there was kind of a mass just behind the lens, and it was regarded as something behind the lens. That's retrolental fibroplasia. But with there are three epidemics till now. The first epidemic is in 1940s when there is unregulated oxygen, especially in US and West Europe, and it continued till a decade from 40s to 50s with uncontrolled 100% supplement of oxygen. While like for the babies, even when they are in utero, it's 20 to 25% oxygen, they are surviving. But when they're exposed to 100%, and this is the main culprit of having problems in the eye. Now, the second epidemic happened in 1960s, especially in the developed countries when there is advances in neonatal care and increased survival of smaller baby, but then again, disparity of other services. And now we are in the third epidemics. We are still going through the third epidemic. We started from 1990s. That is developing countries, like especially like low and middle income countries, when we have sufficient resources to save premature babies, but there is no sufficient resources for the optimal perinatal and prenatal care and regulate and monitor oxygen. That is the reason for development of eye problems in premature babies, and we are still going through third epidemics because of the blooming of neonatal services. Now, the risk factors, if you go into the risk factors, there are major risk factors, there are alternative risk factors, and there are many literatures and studies in favor of these. And the most important risk factor, no matter what it is, the birth weight and gestational age are the most important risk factors. Birth weight meaning by anyone less than 34, 35 postmenstrual age, and gestational age, and the birth weight is less than 200 kilogram or even less. And there are different screening guidelines in different world, especially in the developed world. The parameters are very less compared to ours. And other risk factors like prematurity, anemia, sepsis, apnea, these are there. So as I said earlier, prematurity, gestational age, and birth weight are the major risk factor, and along with that, oxygen supplementation when these premature babies are kept in NICU for the survival of them. And alternative risk factors like maternal factors, especially prenatal and perinatal factors, infant factors, comorbidities and treatments, and genetic risk factors. If you go into the maternal risk factors, these are like when the mother have pregnancy-induced hypertensive disorders, maternal diabetes mellitus, maternal medication use, maternal age, and smoking. These are, in fact, although there are many literatures and studies, the main factor is these all contribute to the intrauterine growth reduction of the baby that is leading to, and also complications of pregnancy causing premature birth. That is the, like, although there is no direct incidence of having ROP, but then like supplemented with all these risk factors. Similarly, assisted conceptions, like like nowadays, artificial fertilization, like especially in vitro fertilization, is more common, and that is causing multiple births, twins, triplets, and that is the main reason. They are small, they're alive even at 24, 25 weeks of birth. Those are we are not directly kind of saying against intravitreal fertilization, but these are the associated factors. Again, the mode of delivery. What the studies say that it is more common in vaginal delivery compared to cesarean section. Again, there's a theoretically, yes, in vaginal there's a chances of infection, and then other sepsis, as well as the prolonged labor that also causes immunity that causes that affects the infant. And in cesarean, what happens? These are all everything's are monitored. The delivery time is also less. The chances of infection is less, and also like premature ruptures of membranes and chorioamnitis. These are all causing sepsis in the baby. Now, infant factors like race and ethnicity, like there's like Caucasian there's Afro-Caribbean population have premature a tendency having premature birth, but in comparison to the Caucasian population, the chances of retinopathy is less. So that could be because of the genetic factors, and could be other factors as well. And in gender, there's hardly any difference. But then the severity of ROP is more in male gender as compared to female. And twin and multiple births, again, because they are small and they're alive even in a small, in a less gestational age. These are the risk factors. And APGAR score, again, in 1 minute or 5 minutes. These are again the parameters of the condition of the premature baby. If the APGAR score are less in 1 and 5 minutes, that shows that the comorbidity, that mortality and morbidity of the babies will be high. Similarly, pulmonary complications, respiratory distress syndrome, when there is a support like mechanical ventilator, CPAP, continuous positive ambulatory pressure, bronchopulmonary dysplasia, anemia, transfusion erythropoietin, patent ductus arteriosus. These are all, associated risk factors, and necrotizing enterocolitis, bacterial and fungal sepsis. These are, again, sepsis. When there's sepsis, babies will have intravenous antibiotics. These are all, again, risk factors for retinopathy of prematurity. Genetic risk factors, of course, there are many genes, associated with retinopathy of prematurity, but then again, there is no clear-cut, saying that, of course, this particular gene is causing this one. And, there are still many studies going on, and longitudinal studies are needed. Now, let's go back to the normal retinal vascularization before we go into the prematurity. So the normal retinal vessel begins at 15 to 18 weeks of gestation. As you can see, this is the optic nerve, optic disc. And this is the location for cord of mesenchymal spindle-shaped cells that grow out from the optic disc. And this begins around 15 to 16 weeks of gestation. And retinal blood vessels, as you can see, sprout from this optic disc temporally and then nasally. Now, vascular development, usually this is the nasal aura, and this is the temporal aura, and this is the retina. And as you can see, the vessel starts developing and it ends at 40 to 40. That is the normal gestation period of the baby, like 40 to 38 to 42 weeks. This is the norm, 40 plus minus 2 weeks. So this is like 40 weeks is when the temporal retina is complete, the vascularization of the temporal retina. And the nasal retina, there it is about 32 to 36 weeks in gestation that is complete. So meaning by now, if the baby is born around 32 or 34 weeks, what happens? This 32 weeks is here, and this whole part from 32 to 40 weeks, these are avascular. That means there is no blood, there is no formation of retinal vessels at that time, at that area. Now, the main, especially as the babies are in a very hypoxic situation when they are in their mother's womb, like 20 to 25, partial pressure of oxygen. And when at that time, what happens, there is production of this hypoxic inducible factor, which controls the production of vascular endothelial growth factor, and which is the main reason for the growth of the retinal vessel. There are two mechanisms. One is the vasculogenesis, which covers vasculogenesis is the center 1/3 of the eye, which is formed by the primitive vascular plexus from the precursor cells. And from the center part, 1/3 outside, from the pre-existing vasculature, there's a sprouting happens, and it is called the angiogenesis. The vasculogenesis is not dependent on anti-VEGF, VEGF, not dependent on that, but the beyond 1/3 outside the angiogenesis part is dependent on VEGF. That is where the main problem of ROP happens. And because this upregulation and downregulation of VEGF, insulin-like growth factor, are the main factors for formation of new vessels and avascular area. Now, when the premature delivery happens, what happens? It is divided into phase 1 and phase 2. Suppose if the baby is born at 31 and 32 weeks, what happens? Initially they are in the hypoxic state. The oxygen level is very, very low. But then when they are exposed, they are born, and when they are given high oxygen level, they go into the hyperoxic environment. There's a high percentage of oxygen. Now, because of that, there is angiogenic factors, especially this growth factors and all, it degrade or down regulates, and that delays retinal vascularization. And now the phase 2 is neovascularization. When there is a vaso-obliteration of the first part, there is down regulation, and now what happens? That causes hypoxia again, and now the hypoxia that overstimulate production of angiogenetic factors, especially VEGF, and these vascular endothelial growth factor causes uncontrolled retinal blood vessels. As you can see from the picture, this is a normal one. I think the picture is not a bit clear. This is in the premature babies, endothelial growth factor, insulin-like growth factor, erythropoietin, and omega fatty acids. These are all at the lower level. Now the hypoxic condition, it increases and new vessels happens. So this phase 2, when we treat with laser anti-VEGF, that controls, and in the initial phase, try to monitor oxygen, like give proper care. So those are parameters to prevent ROP from happening. Now, pathogenesis again. There are two important hypotheses. One is the classical theory, and another one is the spindle cell theory. Now, according to the Ashton, actually, like the main cause of this is supplemental oxygen administration as the main causative factor. What happens? Now, if the baby is given 100% oxygen, what happens? There is elevated arterial partial pressure of oxygen that causes retinal vasoconstriction, now lead to vascular closure, and that leads to permanent vascular occlusion. Now, what happens when now these babies when they are returned to the normal room temperature, what happens? Now, these closed arteries try to open, and that's when there's all down upregulation of vascular endothelial factor happens, and there's angiogenesis, and because of endothelial cell, proliferation. Now, another one is that the Fraser has postulated that spindle cell theory. This is usually what happens, like in avascular retina. Suppose that the zone 3, I'll come into the zone part. Zone 3, these are avascular, and especially in the avascular retina, it is avascular, and they have plenty of spindle cell. Now, what happens because of this hyperoxygen, the spindle cell gets damaged, and because of this damage, that causes, induction of this retinal and vitreous neovascularization happens. Now, another current theory is the growth factor theory. Again, this is again to do with vascular growth factor, insulin, like growth factor. These are all interconnected. This is again the vascular growth. Now, this growth factor shows that this directly linked with vascular endothelial growth factor, because of the hypoxia causes rebound increase in VEGF, leading to uncontrolled neovascularization. Now we know, the basic definition of pathogenesis. Now, once we come into the ROP, now how do we classify retinopathy of prematurity? For this, we need to understand about the international classification of retinopathy of prematurity. There's a lot of studies, and along with a lot of, the like-minded, consensual, people around with their, findings, which was published in Archive of Ophthalmology in 1984 and also in 1987. We need to first, they have defined as, they have defined into zone 1 and zone 2 and zone 3. Now zone 1, this is right eye and this is left eye. So this is the optic disc. and there will be the fovea, and now you draw a line and double this one. So from there, you draw arbitrary imaginary line, this becomes zone 1. And from here, from the edge of zone 1, now go into the ora serrata. Ora serrata means like when the premature baby is, they're born at 34, 36 weeks, that the nasal aura is the aura that has already been formed. So from there, again, draw an arbitrary line and go into, so this becomes zone 2. And the remaining temporal crescent, which is formed after 36 weeks to 40 weeks, this is zone 3. And this is the main area where, avascular retina happens. Now, this is again the similar picture. Disc macula, this is zone 1. From here, nasal aura, this is zone 2, and the remaining is zone 3. And another one is we need to monitor in clock hours, like this is 3 o'clock, 6 o'clock, 12, and 12 o'clock. This is how we classify the eye. And now the eye should be classified on the basis of zones, which we already mentioned. Now the stages, stage 1, 2, 3, 4, 5, extent in clockwise and plus disease. Now, stage 1 is the demarcation, and I'll come into that. Stage 2 is ridge. Stage 3 is when there is a phase of neovascularization. Stage 4 is partial retinal detachment. Stage 5 is retinal detachment. Now, as you can see, this is in this picture, this is a vascular retina. This is completely without any vessel. This is a vascular retina. So you can see the demarcation line, yeah? So this is stage 1. Now the stage 2 part is when the demarcation line gets elevated with the mesenchymal shunt joining arteries and veins. These are stage 2. Now stage 3, the same elevated ridge with extra, extraretinal fibrovascular proliferation, as you can see. Either it goes into the retina or it comes into the vitreous. So this is stage 3. And this is for the vessel pattern again. Stage 1, this is demarcation line. This is, ridge. This is along with the plus disease. This is stage 3. And as you can see, this is stage 1. Look at this faint line, demarcation line. This is stage 2, and this is stage 3 with neovascularization. Now, stage 4, according to ICROP, is the partial retinal detachment. It is stage 4A and 4B. So this is extra foveal when it doesn't involve. But then look at the clock hours. There are nearly 3 clock hours here. This is stage 4A, which is still treatable by medical treatment, not by surgery, what I mean to say. And now this is when it involves fovea. This is with the retinal detachment when we need to start interfering with surgical treatment of ROP. Now, this is stage 5. This, I would say, it is kind of a very difficult and the late stage, and still many of the babies in this area, it comes at this late stage. Now, anterior is this one, and the posterior, when it is open. They're different categorization. This is open. This is narrow posterior end. This is anterior is narrow. This is the type 3, and now this open behind and narrow and narrow. So these at these stages, it is kind of it's the configuration in the funnel shaped, and only therapy we could offer at that stage is surgery, at that also with the guarded prognosis. Now, we need to again define in line of plus disease. Now, this is the hallmark of severity of disease. As you can see from this picture, these are the venous dilatation and arterial tortuosity. Along with that, the pupil is very rigid. There's a poor pupillary dilatation because of the venous engorgement of the iris here and vitreous haze. That shows the eye needs urgent treatment or this is a severe kind of ROP. Now now that 1984 and 87, that has been revisited in 2005. Because they haven't mentioned about the aggressiveness of the vascular pattern, pre-plus disease, and clinical clarification of extent of zone 1. That's when the ICROP is revisited in 2005. Now, the pre-plus disease, this is like slightly less than plus or plus disease when there are vascular abnormalities, arterial tortuosity, but less than plus disease, but then that may progress to plus disease requiring treatment. Now, AROP, which is the aggressive posterior retinopathy of prematurity, look at this picture. You can see, increased dilatation, tortuosity out of proportion in all four quadrants. There's AV shunts here. You can see there, AV shunts here. And new vascularization also, it can be flat or can be featureless. It doesn't necessarily it has to go from stage 1 to stage 3. From stage 1, it can directly go into stage 3 or 4. And previously, it was known as rush disease. Now, this one, again, ICROP was again changed with certain parameters in 2021. They're from ophthalmologists from all over the world. They, kind of discussed, had lots of meetings together and come into, a conclusion that we need to redefine in lines of zones, plus and pre-plus, stage of acute disease, AROP, which was APROP converted into AROP, retinal detachment extent. And there was no definition of regression, reactivation, long-term sequelae, but then ICROP 3 has formulated that. And, we should go into that ICROP. There's an article, this one, this is like, for me, it is like it's a textbook for me, when you have a problem, just go into that and it details everything, this guides you. Like if you go into the zone, I wouldn't go in detail, especially for zone 2, they have categorized into zone 2 anterior and zone 2 posterior. And zone 2 posterior is regarded as treating condition. Plus and pre-plus disease, when they focus just on we need to, according to that, we just need to focus on zone 1 only. Stage of acute disease, like if it is, in previously they used to say mature retina, immature retina, but then they have coined as incomplete vascularization or complete So there is a change in terminology. AROP also, like it is not just posterior, it can be in anywhere. It can be zone 1, zone 2, irrespective of all. So it is the aggressive ness of the ROP in any zone of the eye is AROP. And again, retinal detachment, they have changed certain parameters. It's better, I think, I would request everyone to go through this article. Now, threshold ROP, there are different terms. Again, a little bit confusing actually, but then this is needed for the treatment guidelines. Is a threshold ROP, it is a condition when there is a 50% risk of retinal detachment if not treated. It is when it happens in more than 5 contiguous or 8 cumulative clock hours, stage 3 plus ROP in zone 1 or zone 2. That's the center part which needs to be treated. Similarly, pre-threshold, any zone zone 1 ROP less than threshold. Zone 2 stage 2 with plus. I'll show you with the pictures. Zone 2 stage 3 without plus. Zone 2 stage 3 with plus, but less than 5 contiguous, less than 8 cumulative. And for these, we need a close follow-up because they can go into the threshold anytime. Now, according to ETDRS study, now again, they are classified into zone type 1 and type 2. Type 1 is always severe form of ROP, which needs treatment. Like if you see, this is the zone 1 ROP, when the vascular abnormality, new vascularization, etc. It happens in the zone 1, that is the zone 1 with any stage and with plus disease, this is type 1. Now zone 1 with stage 3, when there is new vessel but no vascular tortuosity, that is also type 1. Now zone 2, this is the zone 2, but stage 2 or stage 3 ROP, when there is vascular tortuosity or, new vessels, these are severe form of ROP and they need treatment, urgent treatment. Now, type 2 ROP is like if it zone 1, but the stage 1 or stage 2 ROP without plus disease. And now stage 2, even with zone 2, even with stage 3, when even there is new vessel, but that without plus disease, we can observe. But then, meaning by we need to monitor very, urgent, quickly, it can go from type 1 to threshold needing treatment immediately. Now let's go to the screening part. Screening part, the rule of thumb. The rule of thumb is 4 or 28 days of life or 4 weeks of birth. But saying by if the infant is less than 1200 gram or 24 to 30 weeks of gestation or less than, I would say, 30 weeks, then we need to screen at 2 to 3 weeks after delivery, because we have seen frank kind of ARP even in 18 days old baby. And those are categorized in a very, primitive, very premature babies. Then we need to see within 3 weeks. And so the rule of thumb is 4 weeks and not later than of course, not later than 4 weeks. Now, for screening, what do we need? We need, because these premature babies are, especially they are, with all these tubes and, veins and open and all, they are in NICU setup. So we need to, because they are so, health-wise also they're not very good. But then we need to see it properly. We need to dilate people at least an hour before fundus examination, and especially for dilating, we need to be very, very careful because these drops can have systemic side effects. So tropicamide is 0.5% with phenylephrine 2.5%. In 15 minutes difference, not more than 3 times. And if it doesn't dilate, that means the severity ROP is more. That means it needs treatment. And topical anesthesia, we prefer proparacaine. I prefer proparacaine because this is the less, stinging to the baby, and we need neonatal speculum and scleral indenter. As for the feeding, the babies should refrain from feeding at least half an hour to 1 hour. That sometimes it does happen because when there is these are small tiny babies, they can't burp, and so that can lead to aspiration and can be quite serious actually. So also, like, if there is a possibility, because again they can go into hypoglycemia, which is again risk factor, so it's better to give sucrose drops in pacifier during examination. So what do we need during screening? We have either 20 diopter or 28 diopter. 28 diopter is for the basic screening of the eye, whether vascular pattern and all. But then if you need a detail about which zone, which area, which extent, it's better to do with 20 diopter. And especially for the laser treatment, it's better to use 20 diopter as well. We have a special kind of this speculum. We use indenter or cotton tip applicator is needed, because to look at the far periphery zone 3, we need indenter. Now for the procedure, so especially as we do it in a neonatal setup, we need to inform. Like if it is in the outpatient, like ours is the tertiary referral center, where the babies are referred, and but still we need to inform beforehand to whoever meets the screening criteria, we need to inform about the examination. And they will, for the paramedical staff will administer eye drops as advised by the doctors to dilate the pupil. In neonatology, DIPA unit, it will be the neonatology staff. And, we always need to wash hand because they are so tiny and they are prone to infection. And then also, like, it's better to always wear gloves and apply local anesthetic or apply speculum, and someone has to hold their head and wrap the baby in a way that the movement of the baby is less. And First, when you see, and of course, the light needs to be dimmed, or there's no light at all, a very light background. First, we start with the lens and see the anti-segment anomaly. See, look at whether there's any vessels, tunica vascular lentis, or and also look for plus disease. And always start screening the nasal retina first, because this is easy to access, and use scleral depressor in all clock hours, slow by slow, looking at the type of, the involvement of whether it is avascular or, incomplete, complete. And it's always preferred to draw a retinal chart. With nowadays, tele-ophthalmology and telescreening and all, we are using, a small probe where the images are drawn into the, cloud and all. But then it's always better for your own to know the extent and all, and it's always better to use a retinal chart. Also fixed time for follow-up, document, especially consent for the babies, for these, screening with the parents. It's because they are already apprehensive, and the baby starts crying and all, it sometimes it's become so chaotic. We need to give a lot of time counseling them. It's not going to harm, like it's mainly for, because they can't see. So it's mainly for their benefit. So, and also we need to explain status to the parents, and sometimes they won't allow even to touch babies. And, we really need to be very patient to be able to explain or counsel them. Now, as for the screening guidelines, so the screening guidelines is different in different worlds, depending upon the prematurity status and gestational age. And UK ROP screening guidelines, it is 1500 birth weight and 32 weeks of gestational age. And American guidelines, again, 1500 to 30 weeks. And we do not have a proper guideline as such. We follow Indian guidelines, and Indian ROP guidelines is 2 kg and less than, or 34 weeks of gestational age. And in Sri Lanka, it is 1500 gram, 32 weeks less than gestational age. In Bangladesh, again, 2 kilogram and less than 35 weeks of gestational age. With, I've taken it from different sources, as you can see. And this is kind of a, overall from different countries. Here, this is slightly old one. As you can see in India and UK, there's a parameters is slightly different. We have Argentina, Brazil, Canada, Chile, Colombia. And it's not just gestational age or birth weight. Sometimes, suppose the baby is around, like 34, 35 weeks of birth. But then if they have, other risk factors, if the baby have unstable path like sepsis, respiratory problem, multiple birth, as well as if they are in a prolonged oxygen therapy, those are associated risk factors. And even we do not just stick into the 34 or 35, we can, even with the associated risk factors, they can come under screening. So we do screen them. But then again, we always need to remember this is the magical number, like it's 1, 2, 3, and 4. 1 is 1 month immediate after the birth. The baby needs to be screened no matter what. Less than 2 kilogram. So there's 1, 2, and less than 34 weeks of gestation. So 1, 2, 3, 4. I know in different countries it's 31, 32, but then if you remember that way, we will never forget to screen these premature babies. Yeah, okay. Now let's move into the treatment part. We need to decide first. Now we have seen the baby, we've screened them, we have kind of a categorized. Now decision whether to treat or not treat, we need to decide. It's not the treatment of ROP only. ROP is very small to the eye, but then we need to correct systemic factors, like baby might be having anemia, because less than 10 hemoglobin is always risk factor. No matter, even if you treat ROP, it's not going to, the chances of recurrence or the healing is very delayed. And also if there is a persistent sepsis, they need to be in antibiotics, and those corrections are needed. And as well, and the post-treatment follow-up is equally important, because it's not a hit and run case, because we need to see them for a longer period of time. And visual rehabilitation, like they might develop myopia, they might develop cortical blindness. We need to think in that way. So this is the basic treatment line, which I have already, spoken in earlier, slides. Threshold stage 3, type 1. Any type 1, like in type 1, both need treatment. Type 2, they can wait and watch, and we say either 1 week, 2 weeks, depending upon the severity of the eye. Now the treatment modalities. Now the cryotherapy is kind of obsolete now. Laser photocoagulation is still gold standard, without the recurrence, and there's a very less. Now this is the era of VEGF or anti-VEGF. More and more our babies getting anti-VEGF, and in advanced days, buckling and vitrectomy are done, which is, if we screen and treat early, they won't need to go into the surgical part. That's the main aim of this, awareness and screening. And other factors nowadays is systemic propranolol, gene therapy, insulin-like growth factor, omega fatty acids. These are all, stress factors, that the vascular endothelial growth factors. These are all for the regulating these, for angiogenesis, but these are not kind of 100%, and these are still in the preliminary stage. And there are so many, there have been kind of a propranolol, they have meta-analysis, just 8 studies, and it is not conclusive at all. So when to treat? So if it is zone 2 and zone 3 ROP, always do laser. We prefer to do laser, because anti-VEGF should be confined to zone 1 or posterior disease. And of course, for retinal detachment, vitreous detachment, pars plana vitrectomy with lens sparing or lensectomy is required. Now, the cryotherapy, this is a kind of obsolete, but still, when there is poor pupillary dilatation, vitreous hemorrhage, people sometimes do prefer cryotherapy. It is applied externally onto the surface, and until the entire vascular, retina is ablated, allowed about 35 to 75 applications are made. But then, the eye becomes very edematous, is painful, and it has to be done under general anesthesia. Now, this is the gold standard, and that's the best part. It's always laser treatment is the gold standard for ROP, still gold standard, and even in the future, I think it still will be the gold standard. This is easy, especially for zone 1 and zone 2, easy to treat, because we can indent and look at zone 1 and zone 2. These are less invasive, less traumatic, and less discomfort for the babies. And it has to be not like in diabetic retinopathy, like we just give 1,000 spots, or like in successive stages, but not here. ROP, we need to do laser as much as possible and confidently. Initially, of course, 1,500, but then it can go up to 2,000 spots, and with 1,000 laser burn apart. So look at this. These are the avascular retina. It's totally, we need to ablate. And with this one, with the laser, and these are the elevated in the posterior zone. There are 2 rows to be given at the elevated edge, not at the mesenchymal, but at the vascular edges there. We need to give this. Those avascular area as well as this one. And there are 2 different types of laser. One is diode laser. Diode laser is supposed to be for the ROP laser, but we do argon laser as well, because the diode laser has more inflammation, and the studies have shown that there's no difference between argon and diode in regards to the prognosis. The advantages, it's very useful when surgery is needed. Peripheral avascular retina is totally ablated, and there is less chance of regression, and no frequent retinal examination needed as in regards to anti-VEGF, this one. And unfortunately, I couldn't open this video. Usually this is already done. What we need to do is we first start in a row like this, like from zone 3 come to zone 1, zone 2, in this manner, in the quadrangle manner, and then ablate. So what I mean to say is make a barrage, kind of a barrier, and then go inside and do the laser. Wait. Only thing is the disadvantage of laser is sometimes general anesthesia will be needed. It's long and tiring. It's a steep learning curve. Initially when you start, we don't see anything at all. As you go on doing it, you become perfect. That the laser, and especially for the indirect laser, you need to be able to see, do the indirect laser in adults retina. That is, if we are expert in doing that, there shouldn't be a problem in doing in laser in infant. So sometimes it can cause, not sometimes, it can cause peripheral visual loss, like in other laser part. It can lead to high myopia and astigmatism when plenty of laser spots are given and in successive manners, and astigmatism. It can lead to anti-segment ischemia. It can lead to exudative retinal detachment. It can lead to more inflammation and posterior synechia. So it can sometimes cause bone in cornea and iris, cataract, retinal and vitreous hemorrhage, retinal hemorrhages as well sometimes, like especially in diode. If we do, if the baby needs plenty of lasers, then it can cause these ankylosing. But then the complication is very, very less. But then we need to be vigilant about this. And okay, now before as for the let me just go into regression following laser. So for the laser therapy, there's no change. Initial few days, we do not anticipate any changes at all. But then as you go like a week apart, this slowly starts, the new vessel and plus disease starts to regress or decrease. In 2 weeks, we see a definite changes, like plus disease and extents of disease regress significantly. But if we think there is no regression, now check for the skip areas and we need to treat them as soon as possible. And 2 to 4 weeks, a new vessel completely regressed to minimally elevated edges. Now the follow-up, it's better always once you do the laser, follow up a day immediately, and 1 week, 2 weeks, 4 weeks. So till you see the total regression of plus and NV in ridges, and also sometimes you try to look at the vascularization starts over the scar and goes into the zone 3. We need to look at that. And by like 45 weeks, laser scars form from the laser areas, and raise regresses, but then it can continue up to 6 months. So that is when we need to follow up quite long. And sorry, this one now, follow visits. In general, follow visits, if it is incomplete retinal vascularization, we need to check every 2 weeks. And if ROP is present, then every week till because that is again, what if the baby the progresses in regards to ROP, that is always fair in your mind, and we can kind of of course there is a definite guidelines for that, but then sometimes we need to judge by our thoughts as well. And if it is pre-threshold ROP, which might need treatment, then try to bring them as early as possible. So look at the follow-up. Even one baby is coming so many times. The factor for the parents, premature babies coming to follow up, there's so many factors. And the babies, even though there are one or two you're treating, but then with the follow-ups, as if you are seeing a lot of babies in few weeks. So what I mean to say is that this is the burden for all of us, for the treatment, for screening, and also counseling part, and the medical legal issues is getting more and more with this, and it's a highly sensitive topic actually. So we really need to be able to screen, refer, or treat so that, the burden of ROP is less to the society. Now, next we'll go to the treatment part. This is just to show that, the laser, we are doing laser in general anesthesia, injection, and again laser. This is the ROP team. And now this is the anti-VEGF era, anti-vascular endothelial growth factor. It is the main indication when it involves zone 1, especially type 1 ROP with zone 1 involvement and AROP. These are the definitive indication for anti-VEGF. There are three different anti-VEGF right now. Bevacizumab, it's always half adult dose according to beat ROP, and there's so many studies have confirmed that 0.625 milligram in 0.05 ml of Avastin bevacizumab, ranibizumab 0.3 milligram in 0.01. Nowadays, they are using biosimilar of ranibizumab as well, and aflibercept or Eylea 0.4 milligram in 0.01%. These are different anti-VEGF, and these are like a magic drug, we always need to follow this safer technique for anti-VEGF. The needle has to be very short, 4 millimeter. It has to be proper antiseptic, and follow-up needs to be regular immediately after the first injection. And where do you inject? Because as you can see, because the eyeball is so small, it's 1 millimeter away from normal anti-VEGF. We give a 3.5 to 4, but there it is just 1 millimeter away from the limbus. Or if very low, very premature babies, 0.75 millimeter away from the limbus. It's hardly any, like it is just close to the limbus. And recheck every 1 day and 1 to 2 weeks following injection till maturation happens. Usually, the first day, and we do not need, although it's there, second or third day, because chances of endophthalmitis there. What we usually do is we look at, we see on first day, and then follow up on first week, second week, and 4 weeks till you are happy that, okay, it's not going to progress. Monthly until there is total regression of plus and NVE in the ridge, and or until complete vascularization happens. And the second injection is very, very rarely needed. Only apart from ranibizumab, there is chances of recurrence. Now, advantages of this one as compared to the laser, it's easy procedure. It can be done in topical anesthesia, and also preservation of peripheral vascular field because we do not need to do laser. And myopia is less than laser. But however, there's a chances of endophthalmitis and also the lens and retina, because the direction of how you needle inject along the visual axis, sometimes you might hit the lens because the lens anteposterior diameter is quite big in premature, the babies, can damage retina. And potential side effects, although it is unproven, but we do not know still yet what are the systemic side effects. But sometimes it can happen with autism. These are cortical visual impairment. These are slowly coming up. So, but then, as always, a risk and benefits we need to outweigh. Which is more beneficial, systemic side effects or benefit to the eye of the premature babies. But with this one, there is chances of persistent or peripheral avascular retina. Late reactivation can develop into lattice degeneration and can be prone to rheumatogenic RD. Now, reactivation. Reactivation, now it has regressed, but then again, either partial in a small vascular pattern or full after full regression. Usually happens after, like about 35 to 60 weeks, and usually mostly after anti-VEGF, but very, very rarely after laser. That's why laser is, has a lot of advantages over anti-VEGF. But then if happens, then it can become very aggressive disease. In such instance, like there's a combination therapy of laser is required. If it happens in early phase, then anti-VEGF injection, again, even 1/4 of the adult dose is to be given. Otherwise, laser treatment is best for these reactivation of this disease in such instances. And there's always a need for a combination. Like you inject first, and then continue observing till 4 weeks. And if there is still, complete the regression is not happening, and peripheral anterior PAR is there, there's incomplete vascularization, then we combine with a laser. So that is the combination and full treatment for ROP. Now, when to consider surgery? When there is late onset like macular ectopia, when the especially angles between the arcade vessels, that AV junction becomes narrower or arcade, then we need to think, okay, that this baby is not need to be considered for surgery when there is a traction retinal detachment or new vitreous or retinal hemorrhages. Now, when do we stop screening, or when should we terminate screening for these? In fact, the screening or examination of babies never stops, to be honest, because long-term, follow-ups are needed. It especially depends on, like, if there is no retinopathy of prematurity, we wait till full retinal vascularization. We consider it is either 40 to 42 weeks of postmenstrual age. When there is complete retinal vascularization, then we do not need to see them. But then we need to refer them to pediatric ophthalmologists to rule out any other factors like high myopia or strabismus, that is in the later. Usually when around 5 to 6 months of age, that is for the normal with no ROP. But then if there is ROP, then we need to follow them for a longer period of time till we see that, until regression happens. Of every 1 to 2 weeks, it can go even up to 65 weeks of postmenstrual age. Now, the long-term management, now, although the complete retinal vascularization is complete, they are to be seen up to 5 years of age by pediatric ophthalmologist, general ophthalmologist, especially for, whether there is refractive error, the very high myopia, strabismus, amblyopia, cortical visual impairment, and persistent vascular retina. It can happen even in a later part of the life. We have a couple of cases actually when they are here for the routine review for the myopic, correction and all. We look at the eye and we go back to the history, and there is, a history of prematurity. Then that means the persistent avascular retina can happen even in the later part of the life when they need a laser. Now, sequelae of ROP, as you can see, there is a dragging of, phobia temporarily. This is kind of a cicatricial ROP, or when the ROP, that causing macular heterotopia when this dragging, and cicatricial ROP. This is even worse than this. Like there is a disc dragging, there's a fibrotic changes all along. Those are again in stage ROP. Now, now we need to. Okay, now these are all. I think I've covered mostly the screening part, diagnosis part, pathogenesis, and now, we need to also know about the new screening modalities of like tele-ophthalmology, because, like it's not always possible for babies to come from NICU to be transferred to tertiary referral center to be seen. It's always best, if someone gets trained and to be seen in NICU itself, paramedical staff, and also especially in our countries like low and middle income countries, ours, probably Bangladesh, Pakistan, India, because of low lack of resources and lack of manpower. Even look at our country, like number of people who do retinal screening and treatment, and is very less compared to the overall NICU babies alive and with good care. So there is always a disparity among these resources and on manpower and traveling to different areas, and even for them to come to the center, it's so difficult. So there is a development of tele-ophthalmology. These are the cameras. Initially, it's RedCam 1 and RedCam 2, which is mostly used in developed countries. We have facility for Forest New. It's like a RedCam, along with the camera. It's a handy, that can be transportable to different parts, and people can be easily trained to take pictures in NICU, in different community eye centers, community hospitals, and these images, of course, they need training for taking images, and these images are taken in different quadrants, and these images are stored in data sets, and the ophthalmologist at the base center can diagnose or categorize whether they need treatment or not, whether they can be screened. And this is in NICU in Kathmandu Medical College with the Forest camera. So these are mobile self-contained system. We can take into NICU, ICU, operating room, that avoids stress, and we do not need to do indirect ophthalmoscopy and indentation also. Like expertise of those ophthalmologists also is less. And this is again teaching tools for residents and parents. It is easy for them, even for the parents, we can show them, okay, this is this, this becomes a kind of a proof for us. Although it's little bit time consuming and can be stressful because the baby will be crying. And again, the apprehensive parents, even for those, those are the things we need to keep in mind. But then there's the case management becomes very easy as we have access to images, video clips, patient data, and then we can kind of even do kind of a research and all. And also then can be retrieved. And also nowadays, there are so many smartphones can be, combined with RedCam, and this is and these are very, very affordable and reasonable for low middle income countries to buy and utilize it in the local settings. So these are the tele-ophthalmology, that we need to develop. We do have tele-ophthalmology in our country as well, but then we need to develop in more and more areas so that we can catch more premature babies. You must have heard of Kidrok, that Karnataka based that assistant, that by Dr. Anand Vinikar. He's giving another talk next week on 24th about the telescreening. He is the one in India, of course, in LVPI also, that those are the two main centers who are doing telescreening, tele-ophthalmology, and they are also developing artificial intelligence with the images taking and grading and all. They are graded by AI and graded into whether it needs referral or treatment warranted. They categorize, and then they by artificial intelligence. So these are the level of ROP screening we need to move on, and this will definitely help us to eliminate ROP blindness. Now, fortunately, today we mark, it's the World Prematurity Day. As the WHO has standardized this today, meaning by it's around 1 in 10 babies are born prematurely, and also out of those one, count as, those are, suppose there are 100 babies, one out of 10 babies, one means like in 100 that 10 babies are prematurely born. And even in premature baby, about 30% will have some form of ROP, and 7 to 10% will have treatment require an ROP in view of lasers, injection. Those are the main people who needs attention. And there's a legend, Stevie Wonder, as we all know. He's born at 34 weeks of gestation on 1950 when the ROP, the first epidemic started. So yes, this early screening and timely intervention is the only way to prevent ROP blindness, and we need to do a lot of these kind of awareness. We need to teach others, our colleague, like how to screen, and also especially the awareness of 4 weeks of birth. Go to the any eye hospitals, get your baby's eyes checked and screened, and it needs treatment. So yes, thank you all, and that's it. And I'm ready to take any questions if you have. Okay, now there's a question by Lucia. If you're trying topical nefebenic in ROP, this is actually like when we use this nefebenic, especially when we are having difficulty in dilating pupil, then this is used. But there is no as such a role for treating ROP. And there's Sazad of Zal. He's asking, is there any difference between the age of prematurity and management in Southeast Asia and other parts of the world? Yes, there are like, in Southeast Asia, because the NICU backup is more, there is enough resources for NICU, but then the prematurity are, what I mean to say is more. When this the management thing is not different from any parts in different parts of the world, but then the screening criteria is different. Especially in our subcontinent, we screen even more like 2 kg. It's supposed to be slightly more compared to other parts of the world. So that is the difference between ours and others. Yes, and someone is asking, can optometrists do screen RP? Of course, you can, because you are even we are asking nowadays paramedical staff who are trained for ROP screening can do screening, especially for those taking images on. Of course, optometrist can do. And now she's asking why cryotherapy is outdated, because the complications are more, and also if we have facility for anti-VEGF and laser, which are more far beneficial than cryotherapy, we use rather anti-VEGF and lasers than cryotherapy. Do you do laser? And Alina Malamud is asking, do you laser provincially babies after Avastin? Yes. It depends on, not all the babies will need Avastin. Not all the babies will need laser, especially AROP with more plus signs and all. Once we do the laser, although the vascularity sign decreases, but then we still see there's vascularization still not complete in zone 3. We wait till 3 weeks, up to a month, and then we do laser. So it's a combination therapy is always, combination therapy works better. Okay, now BC is asking, how can I conduct a treatment in African countries? And there are kind of a lot of ROP screening going on African countries right now. They are developing, like their guidelines. So you can be in touch with these, especially ophthalmologists who are dealing with ROP screening and RP. You can be in touch with them and you can start your treatment. A gentleman is asking, Madam, can you switch from one anti-VEGF to another during treatment at any stage? Usually anti-VEGF, we do not need many. And it's rather not to switch over because it's always better, like anti-VEGF to do the same within, if there is early recurrence, give half, even one-fourth of the adult dose. And it's always better to do laser therapy rather than doing anti-VEGF. No, and someone is asking, Norman Mazid is asking, can we administer anti-VEGF laser therapy combined on the same patient? Yes, we can, but not on the same day. Because once we give anti-VEGF, so we are we are trying to, decrease the VEGF part. Yeah. With the laser, in fact, it is counteracting. So we do not do treatment on the same in very less span. And usually we wait till up to 2 weeks or 4 weeks for laser to be done. Although there is no clear-cut guidelines, but there are papers coming out now. And also especially it depends on the age of the baby as well. Especially like if the baby crosses 38 or 39 weeks, it's always better to do laser therapy because VEGF concentration goes down at that stage. So even if you do anti-VEGF, it's not going to benefit. And also VEGF is necessary for the development of the body of the baby, like whether it's heart or the brain. So giving anti-VEGF at the later stage of prematurity means we are interfering the systemic growth. And also, like this is a very important, I think, Abhishek Karna. It was is there any precaution for ROP? Yes. Not ROP, it's always better if we try to prevent ROP from happening. That has to start from the utero itself, having proper prenatal care so that premature birth is decreased. Try to avoid multiple births and also having proper care for the mother, especially preeclampsia, diabetic. We need to treat them clearly, properly so that, premature birth is prevented. And especially in pregnant women, these days, oral corticosteroid is given that has a beneficial effect for ROP. And also during neonatal care, have a proper care for the baby, monitor oxygen, try to keep not 100% oxygen, try to keep it in the lower side, like 91 to 92%. Try to do with a blender. And nowadays, so many NICUs are provided with these blenders and they monitor very well. And even in Nepal, the NICUs are better equipped now preventing ROP. And also postnatal growth. This is also another risk factor. We treat them, but the baby is not growing fast. So we need to think about, not us, those around neonatal care, feeding them properly, having proper, care for the babies. These are also preventive measures for ROP. And is there any risk of ROP in consanguinity? Of course, this again, there are studies of genetic factors, and there aren't any studies as such, but of course, it needs attention. And there is what are the roles of nurses in management of a baby with ROP and some of the specific nursing interventions? Yes, as I said, for the proper care of the premature babies, proper maintaining health, like feeding, the growth, antibiotics, and of course, the care of the babies itself from the nursing part is very important. Also, to make aware for the counseling for the parents is also nurses can do very well because they are in so much of close proximity with the premature the babies, parents and all. Counseling part also they can do, and also ask them to take them to, for the ROP screening at 4 weeks of birth. Okay, now there's Bernard Sempa. He's asking, you talked of screening 4 weeks after birth, and what is the reason behind screening 2 weeks after birth for those below 28 weeks of gestation? Now, 28 weeks, this is a high preterm, highly premature babies. So look at if you have, I've talked about retinal development. Now, 28 weeks of birth, that means the vessel are very, very primitive. And if you give oxygen, high oxygen, the effect of those endothelial cells, spindle cells, everything is so premature and so sensitive. Now, the oxygen will have, more stress, the causing stress or to those vascular vasculogenesis, and those things can happen even earlier than 4 weeks of birth. That's why we need to screen them early. Of course, and there is one question asking, do we use steroid eye drops to prevent progression of ROP? We do not. But then after laser, we give topical steroid for 5 days a week. Now, what is the rationale of laser in treatment? What is every session of laser or anti-VEGF? The rationale of laser is we are ablating a vascular zone, so that because a vascular zone is causing all those, again, to do with anti-VEGF cascade up, down, and regulation. This is for that. And the average session of laser, first we do the laser and then we assess. And if you see skipped lasers, we again do the laser. Sometimes we might need to repeat 1 or 2 times. And anti-VEGF usually one time, and sometimes in a case of reactivation, we might need to repeat. Right. How many premature babies have had laser versus anti-VEGF in your practice? We have it's what I usually do is, because ours is the tertiary referral center, and they come in advance in a stage 3 when they need we do both laser and anti-VEGF. First do laser for anti-VEGF and laser, so around similar. I think most of have answered. No, as for now, someone is asking this again, very good question. Can a general ophthalmologist do laser, or does it need to be this retina specialist? Anyone can treat, provided they have a special training for ROP screening and ROP laser. Not necessarily it has to be a general ophthalmologist, especially retina specialist, because there is mainly the lack of manpower. A trained human manpower is lacking. So it's always, even general ophthalmologist, if you have a special interest and you go for the ROP training, screening, and lasers, of course you can do. Now, Sumanta Sen, she's asking, what is the single most common long-term refractive consequences following regression of ROP, and why does it occur? This one is high myopia is the commonest, especially after laser. We have seen even going up to -10 to -12. That is why we need to see them, check them and we need to check their refractive status. And if you give lasers injection and we do not correct refractive error, that eye goes into becomes amblyopic. So the cause of myopia is that the laser scars depends on the scars and how many spots you are given. That is something to do with the anterior posterior diameter, and also to do with the and the contour of the eye, and also with the scleral, when you do laser, it goes up to the deeper layer. So these are all causing, although there is no there is no proper reason why it happens, but then these are the postulated factors. Now, Roxana Soma, let me just answer live. This full-term baby with history of birth asphyxia, should we check retina? Yes, we need to check retina, but then full-term baby means if there will be kind of a complete vascularization is still there, but there is less chances of having retinal complication. But then retina screening is needed for if then due to birth asphyxia that can happen other retinal symptoms, signs that you need screening for that.